a few moments for questions.
10 minutes.
10 minutes. And also, I welcome comments because we have a very august group of experienced individuals in this audience. So perhaps while the first questioner is coming to the microphone, I have a quick question for Dr. Kerr. Toluidine blue is probably the least expensive of our adjuncts. And is it at all technique sensitive?
You know, I've tried it all different ways. I've used the pharmaceutical grade, the lab grade. They all work very well. You're supposed to use the acetic acid first to just set the scene, get them to rinse with some water, apply the toluidine blue, and then decolorize with the acetic acid a second time. And that usually works very well. Joel, do you have any other comments about that?
Thanks. Actually, I agree. I think it might be the most useful tool in that interpretation, I think, is a little easier if you observe the lesion first. So, for example, if there's an ulceration, it's going to stain. You need to know where that ulcer border is and remember that after you evaluate the lesion. But I think it's probably our most valuable tool. I use all of these in combination like Ross does when I'm seeing patients, and I get less benefit on the earlier detection and the biopsy site selection from the other adjuncts. But I will say that probably for margin delineation, that applies, you know, to pre-surgical or even to radiation therapy treatment planning as to field size and lesion size. That the combination is still probably the best. So you have your clinical, you have your imaging being CT or otherwise, and then looking at the widest field of abnormality is what you need to encompass. And so that would include toluidine blue and often beyond that, the fluorescence loss. So I think fluorescence has its best evidence base to date in margin delineation.
Thank you. We have our first questioner.
Hi, I really enjoyed your presentation. Thank you to all of you. I have a couple of questions. The first one is, so we read about the U.S. task force recommendation, and it's neither for or against screenings. And then there's the Cochrane review of 2013 that talked about, that really zeroed on that Kerala, India study that Dr. Epstein was talking about, that had about 190,000 people in both arms of the study. So my question is, from that study, they said that it was really highly biased because of their sampling methods and all of that they used, but they said that for people that were high risk, they found some mortality benefits for massive screening. Again, we know that the geography of India and the risk profile of India is completely different from a place like North America. But my question is, so in a community setting where there's really high risk, low economic status, people who would not go and see a dentist or otolaryngologist until it's late stage, is it okay, using clinical judgment, to have free visual inspection of the mouth as part of oral cancer screening? That's number one question. The other question that I have is, what are we doing as North America? Because the U.S. task force, one of the bane of U.S. task force recommendation has always been that the studies, the big studies, the trials that have looked at massive oral cancer screenings have always been outside of the United States. It's always from India and other parts of Southeast Asia. What are we doing as AHNS, as the group that Dr. Terry Day is representing, as all these groups that we have that have been here for the last 3 days, to design a study that can follow a large number of people and come up with something that can actually give the United States task force something to work with? Because right now, it's always been that there's nothing from the American public that shows mortality benefits of oral cancer screening.
Well, I'll start with the first one. How does that sound? In India, clearly, it's a high-risk community. So what we need to look at is, is screening effective in various or different high-risk populations? And that's part of the problem in the definition right now, is it was easier 20 years ago. But now we have HPV, and how do we roll that in, and how do we screen for that? And maybe we should be looking only for oral. I mean, that's one potential, because we can visualize that better in exam. But I think we do need to design studies that are applicable to the reality of the environment. The study in India was a huge undertaking, obviously, and was very valuable, and certainly there, or maybe other high-risk communities, there's value in that early detection of cancer. And that's different than screening for potentially malignant disorders, which is the pre-cancer stage. And that's something I think that we all have to work towards a consensus on. Do we actually envision screening for that, or do we not have the technology yet? And that's a possibility. But I think for early cancer detection that is meaningful in the high-risk populations, we just have to define how high risk is that. And in all of our communities in the West, we screen for second cancers in someone for 5 years after their treatment. I think that's standard. Now, we also have to look at how cost-effective is that, and that's another issue, and maybe others on the panel want to address that. But we do screen those people for recurrence or new lesions. So we are already doing that, but we have to define how cost-effective that is, but also what other populations should we be looking at. So maybe I'll let others.
You know, I'm going to throw out one term that's beginning to be used to get into breast cancer community, but the term of active surveillance. So the issue is that when we have a patient who's come to us with mild, moderate, or severe dysplasias, they represent an at-risk group. So in our multidisciplinary clinic for our lesions, we try to do a little bit of education, and we sort of tell folks, hey, you know, if you think you have something that's a cold sore, can't let it go for more than 6 weeks, give us a call. So there's these simple things along the way where we have this, we know that our second primary population is at risk, and we follow them for 5 years. But there's also this other population that I know we pay attention to here in our group, but that a lot of times if a person has someone who's a severe dysplasia patient, we found in Minnesota that prior, about 80% of the people, when they had their biopsies done, they were told it wasn't cancer, they got no follow-up. And this was from mostly the dental community. This was we interrogated a dental database at the dental school that had been around for about 20 years, and we went through a full interrogation of that. So I think that part of it is incumbent on us, that if we have someone that's like, hey, you have a moderate dysplasia, don't worry about it. Well, moderate dysplasia patients get cancer about 5 to 12% of the time. So that's up to 10 times riskier than a colon polyp. And there's a whole industry of gastroenterology that's based around colon polyps. So I find that, it's if I have my choice of a colonoscopy or someone looking in my mouth, you know which I'm going to choose. So I think that there is a little bit of that we just, it's not, like I say in my first slide, it's not part of our training. We're not taught to keep the dysplastics in our clinic, but we do in my institution.
I'm Dr. Parekh from India, Mumbai. I've always wondered, we have a group of people which are workers, laborers, and practically the entire community of them are tobacco and betel nut chewers. But only a certain percentage of them develop any pre-malignant or malignancies. What is it, has anybody looked at in such a kind of a cohort group as to what is it that prevents the others who are consuming it not developing it? And maybe we might get an answer from there as to what's happening.
No, that's a holy grail question that comes up with the biomarker community in cancer prevention. And it's always this thing where we want to study the people that have cancers and lesions. I think that we need to study the 90-year-old people that have 100 pack years, never got cancer or emphysema, and there's probably answers in what they're able to do to prevent conversion to malignancy. And that whole population, those people who don't get it, those are the ones who aren't studied because they're not the ones that have the lesions.
Newell, do you want to make a comment? Because I see you sitting quiet here, so, but I think you have, from all of us, you have the most vast experience in this subject, and I would like to hear your views.
No, I don't differ from anything anybody said.
No, over the mic, please.
Just having on the question of who doesn't get cancer. There's been the Holy Grail, and isn't that what held up for some time as taking on board the link between smoking and lung cancer? And patients will still tell you, my father smoked until he died at 95 and he never got lung cancer. Now, I have an aphorism that every malignancy is a unique biological event in a unique host. That, of course, links forward to personalized therapy. But every patient has a different resistance. Every patient has a different genome. And although there might be final common pathways to the neoplasm, there are many different ways of skinning the cat. You wouldn't expect everybody to go through the same process on a molecular level or on a clinical level. Host resistance matters.
I think we have time for one more question, and I believe the gentleman who just sat down, we never got to your second question.
So let me quickly ask this. So we have communities of African American people and other minorities who do not have health insurance, who have very poor history of coming to see a doctor, who would always present at stage 4 or stage 3 or things like that. Is it okay to screen people like this, going to them in the community? Because I know that every year we have the April event where we do an oral cancer awareness week, and Dr. Day spoke about that. Those are people who come to the clinic to us. We do those screenings. What about people in the communities who would never come to see a doctor or a primary care physician or a dentist? What are we going to do to help them increase their awareness about oral cancer and to prevent oral cancer?
Yet another Holy Grail question. Who wants to take that?
I can just answer that a little bit. It's really difficult because I've been involved with a number of health fairs, and patients who are at the highest risk tend not want to come forward to get screened. It takes community leaders who are trusted in their communities, churches. It's different in different communities around the world. They're the people that need to get involved to organize these types of events, I think. I mean, I don't know what anyone else has to say.
There have been studies on churches in poor neighborhoods and how they are effective for bringing patient populations forward with health conditions, whether it's diabetes or requirements of pap smears or anything like that. So there's a whole literature on that. With churches
in
particular.
Maryland, yeah.
Well, I think that we are on time, and I want to thank the audience first and the speakers. And I hope to see you all next year in Sao Paulo for the 5th World Congress of the International Academy of Oral Oncology.